nutrition, and that difference is at least about 2 to 3 days. Now, those who don't work in intensive care, a difference of 2 days may not make much significant difference. But in our life, basically, any baby who does not need intravenous or injectable nutrition, that's a big blessing, because putting an intravenous catheter and giving parenteral nutrition is always a risk factor for infections as such, and it's quite expensive. Not everyone can afford it. So to get on to full milk feeds 3 days early is clinically quite significant. So that is the reason that some people have gone on to say that probiotics appear to be the miracle cure of this century, based on the all data that I've just presented in front of you. So that's the reason that this is some of the argument that why in that case, if probiotics are so good, why is everyone not using it? So that's my job for this afternoon, to take you through all the controversies and find out how many are evidence-based and how many are just dysfunctional arguments. Okay, so this is the list of few controversies that you will keep hearing from conference to conference. There are still some letters to the editor, so this is what it is all about. Number one in front of you is basically the fact that the largest trial of probiotic, Bifidobacterium brevi, manufactured by a different company, I won't take any name, that did not show any benefit of that Bifidobacterium brevi supplementation in a very large, not very large, 1,310 babies as such, conducted in the UK. So they keep on using that evidence to say that probiotic strains, every strain is different, and we have shown for the first time that the bacteria that we use in this big trial in UK did not show any benefit. So we challenge the findings of the previous meta-analysis that ideally you should never combine the data from different strains together, because every strain is unique and individually completely different. So don't combine apples versus oranges. That's the traditional argument. I'll take you through that next one. And I've just covered as I talked that yes, the second argument is that the probiotics effect are strain specific. So talk separately about different strains. Don't combine apples with oranges. Third thing, many people still argue. They still argue that there is not much evidence that probiotics are beneficial for babies less than 28 weeks or babies who are born at less than 1 kilo at the time of birth, which are the extremely low birth weight babies. Yes, some keep on pointing out as probiotics are being used more and more, there are more case reports of probiotic bacteremia or sepsis in preterm infant. Fortunately, not any single baby has died so far in all those case reports. Everyone was treated with antibiotics and everyone recovered. The one case that someone pointed out this morning was basically a death because of a contaminated probiotic product in the US. I think the case was about to go in the court for proper hearing, so we'll wait for the argument. But to my knowledge, at least till 6 months ago, they had not traced exactly where was the problem. And the last thing is people keep on arguing that, yes, probiotics are beneficial, but we don't have access to clinically proven high quality or drug quality probiotic product. We covered the first point here that we don't know how probiotics work is one of the argument. Then some interesting argument that probiotics are not needed if the baby is fed on mother's breast milk, because the mom's milk basically has got good bacteria as well as the prebiotic or what we call the human milk oligosaccharide, the good beneficial sugars. Some people still say if your incidence of NEC is too low, then we don't need probiotic because the risk of probiotic is too much. We don't know how exactly they work. So we are happy to live with our low incidence of NEC, no need to treat. Some people have gone on to be so obsessive and compulsive that they keep on saying that the trial for a large definitive randomized controlled trial of probiotics in babies less than 1 kilo in North America is right now. So that's a very strong, passionate argument as such. So these are the controversies. They are preventing the translation of probiotics for preterm infant. So this is what I'll take you through, the answers to all those controversies, and at the end of the talk, you can decide for yourself what is to be done. So that's the PIPS trial. Won't go much into the details. Bifidobacterium brevi, you've got the dose in front of you. Primary outcome, NEC, late onset sepsis and death. The trial was significantly powered, almost 90% power to detect every outcome. 1,310 babies, median gestational age only 25 weeks, and birth weight only 1 kilo and 10 grams, so reasonably tiny babies. And as you could see that in the result, they found absolutely zero evidence of any benefit for NEC, sepsis, death, and time to full feed. And then they said that the bacteria that they used was of no use, and they challenged the previous meta-analysis. Important is to find out what the results were. So have a look in the table. As they say, the most important findings are always hidden. Like we say that the devil is in the details. So look at the confidence interval and you can find out that the results of this large trial are not negative, they are simply inconclusive. Because the red figures in the bracket will tell you the confidence interval for every outcome. For example, for NEC, the bracket shows 0.68 to 1.27. It means the trial does not have the power to rule out significant benefit or significant harm. If it is benefit, that means up to 32% reduction in NEC. If it is harm, it means it could be causing harm, increasing the risk of NEC by 27%. So simply, these results are inconclusive. The day this trial got published, that very night, I think one of the probiotic organizations, they publicly issued a statement that we reject the finding of this trial because they are not negative and there are many loopholes. One of my colleagues, he wrote a simple blog. He said, this trial is basically inconclusive, it is not negative, and if you conduct 50 odd trials, one trial will give you odd results like this, they are just a random variation. Importantly, the pilot data on which this large trial, this large exercise was based, the dose that they used was 1 billion organisms per day. And for something that I have never understood, that this actual large randomized control trial, they used the dose from 220 to 510 million organisms per day. It defeats the purpose of why did you do the randomized control trial with that small pilot. Normally pilots do have their own play. So all the arguments about the low dose and etc. we have covered in the letters to the editor. Today is not the time and the place to discuss, but you can have a read at that. So that's the reason basically what we pointed out. If you analyze the data of the PIPS trial in terms of colonized versus non-colonized babies, then all colonized babies had significant benefit for all possible outcomes. So to us, basically, PIPS trial is not negative, it is inconclusive. The reason is quite simple, because the incidence of NEC was almost comparable between the two arms of the trial. 1,300 patients are not enough to show you a significant difference. This is another significant argument that has prevented, or not prevented, at least put some barriers for translation of probiotics, that as a purist, as a basic scientist, you would always say that every strain of probiotic is different, so it has to be tested and proven in a large definitive trial, and importantly, you should not combine the data from different trials together in a systematic review and meta-analysis. That will be false. But fortunately, we have Professor Sanders right in front of us. Now, the opinion is slightly changing. The first person to point out that yes, probiotic effects are strain-specific, but to be obsessive or compulsive to that extent, there is not much data, because despite significant variations in the probiotic products, protocols, patient population, people have shown consistent benefit. So there has to be some non-specific protection or mechanism shared by different bacteria. Next person pointed out the same thing was Professor Alan Walker from Boston. He said it is time to accept that there could be some non-specific protection which is shared by all the lactic acid bacilli. Basically, by definition, if they are probiotic bacteria, probiotic strains, then they will have many shared pathways between them. And that might explain why in different trials with different strains, people still see different benefit. And I think I would not get into much details about that, because as I said, both Professor Merenstein and Sanders are with us. They can share more light on the so-called non-specific shared pathways of benefit by different bacteria. This is the paper that I was talking to about. This is the simple answer to the question, that some people say that if the baby is getting mother's milk, we don't need probiotic. These are the two papers. One is Repa from Austria. They have shown that probiotics actually had more significant benefit in babies who were getting breast milk from the mother. Now you could interpret that in two different ways, that yes, because breast milk has got the nice beneficial sugars, so the benefit of probiotic bacteria will be more significant compared to without the oligosaccharides coming from the breast milk. Or you can twist the argument to your advantage and say that formula has got so many adverse effects that probiotics alone would not be able to do any magic. The count of bacteria in the breast milk, even if they are beneficial, is about 10⁻⁴ to 10⁻⁶. In clinically beneficial studies, as you saw, the dose that we use is significantly higher compared to the bacterial colony count in the breast milk. That's another reason that why. And the other thing that I may point out, that in countries like Australia, where breastfeeding basically is almost like 94 to 96%, we still have problem of NEC with the incidence of 4 to 6%. And when everyone introduced routine use of probiotics, the incidence has gone down to 3.1%. Type of feeding, this is the other paper that I just talked about. So Samuels also has reported the same finding, that they found benefits of probiotics more in babies who were on mother's milk compared to exposed to formula. People worry about the long-term adverse effects of probiotics. So far, these 5 studies have been published, which is like a long-term follow-up of preterm babies who were exposed to probiotics in early postnatal life, and you could see none of them have reported any adverse effect. So we will encourage every investigator who has conducted a randomized controlled trial or is using routine use of probiotics, then they should publish the long-term outcomes, especially neurodevelopmental outcomes. The standard that we use, the Bailey scale of assessment of neurodevelopment at about 18 to 24 months. And I know that the Prof.Rama's big trial from Melbourne, they have presented the long-term outcomes of their 1,100 babies in the trial, but so far the full paper is not published, but I know that what they presented showed there was no adverse effect on neurodevelopment and growth after exposure to probiotics. This is the simple answer I gave you right in the beginning, that the argument that we don't know how probiotics work is not a valid argument not to use probiotics for preterm babies, especially when randomized controlled trials have shown significant benefit for significant morbidities as well as mortality. It's quite okay to keep digging deep, like I was discussing with someone, that in the administration world, there's a very nice saying that it's okay to dig as deep as you want, but keep away from the hole. Some people used to argue that if the risk of NEC is quite low, we don't need probiotics. This is the data from Susan Jacobs, that's the Prof.Rama trial from Melbourne. The incidence of NEC was 2.4%. After probiotic trial, it went down to 1.2%, and they themselves have changed clinical practice and they provide probiotics routinely. So the argument that if our low incidence of NEC is low, we don't need to use probiotic is not valid. And don't forget that reduction of NEC is not the only benefit of probiotic, correct? Death, time to full feeds, and late onset sepsis are other potential benefits. Not much data on extremely low birth weight babies, absolutely useless argument. As I told you, at least 3,000 babies less than 1 kilo in randomized controlled trials, at least 5,000 babies in routine use of probiotics less than 28 weeks. So this argument is not valid anymore. So what can we do? So based on all the controversies, if you believe, what are the true problems right now which are preventing the progress of routine use of probiotics in preterm infant? Yes, we need a proper high quality probiotics, because the case report from the US tells us that whole track record of commercially available probiotic product tells us that what they claim on the label is not inside the bottle always. There can be some pathogens as well, and the product may not have been approved properly at a very high stringent level of regulation. If you still want to conduct randomized controlled trial, then it's better to go for cluster randomized controlled trial, because that will prevent the practical problem of cross-contamination of the placebo arm in a conventional RCT. But if you are convinced about the evidence of probiotic, yes, go back and start to use it routinely, but make it a point that you publish the findings as a before compared to after study and control for all the confounding factors using logistic regression, and then you would have created a reasonable high level of evidence that yes, probiotics work in routine use. Dan pointed out in the morning, yes, if you are interested, you can compare different strains against each other. There are many other pending issues, whether dead bacteria are as beneficial as live bacteria, you can study. Whether single is as good as 3 bacteria or 6 bacteria or 8 bacteria, you can conduct a randomized controlled trial. You can find out what are the different ways to find out alternative type of probiotics, including the so-called parabiotics and ghost biotics. So there's a significant opportunity there for continued research in this area, but as a clinical person, I could say that the evidence right now is more than enough to accept the fact that despite all the controversies, probiotics do reduce death and significant morbidity in preterm infants. Thank you.
Thank you, Sanjay. I'm very sure each one of us who are in this auditorium is convinced, looking at that for VLBW and ELBW babies is going to reduce mortality, NEC, and even time to full feed is going to be less. So, open for questions and comments from the House.
Thank you very much. I just have one comment and one question. I think I would argue that it's not ethical to do a cluster RCT with a placebo, that you could do strain versus strain, but to actually put a placebo, I think your data is too convincing. And comment that, but my question to you is, what countries are using this? Are they using it in India? And I know Australia is, but what other countries are using this as a routine?
Australia, New Zealand is using it routine simply because we started that initiation 10 years ago. Almost 75% of Canada is using it. 17% of the NICU in Vermont Oxford network is using it. India, so far, people are using products available on the shelf, but unfortunately, high quality, safe, effective, proven products are not that easy to access, because even our process of importing a probiotic product from overseas is not that easy. And with cooperation between the National Dairy Research Institute and other local agencies and experts and scientists, we hope that the local indigenous product may be soon available in India, that India can use it. As far as the other countries are, the Italians and Germans and Japanese and Swiss people have been using it for more than 15 to 20 years. Japanese people, they laugh at us, they say, what is the big fuss about? We have been using any probiotic routinely from late 1980s. Their incidence of NEC is 0% to less than 1% since 1991. In fact, the first probiotic SPR, Society for Pediatric Academic Medicine USA, that's our highest conference in pediatrics as such. I remember that the first time the Japanese published their finding in that conference, everyone in the so-called Western world was shocked. They thought either this is a language barrier or something is not right here. But time and again, Japanese people have proven that yes, their incidence of NEC is 0 or at the most less than 1% as such since 1991. They all use routine use of probiotics since late 1980s. That is the reason they have not been able to report a randomized controlled trial to satisfy the purists, because they don't have NEC as a problem. Their babies get to full feeds quite quickly. And I was again shocked just last week when I was there for the Centenaries Conference to celebrate 100 years of research on bifidobacteria, that the survival, long-term survival without neurodevelopmental impairment of babies born at 22, 23 and 24 week is 94%. That is out of this world. So that's what I would say, that if there are still people who have got obsessive compulsive disorder and they want to prove that every probiotic strain has to be documented to be safe and effective in a large randomized controlled trial, okay, go for it, but at least conduct a cluster randomized controlled trial to get rid of the cross-contamination problem.
Yeah, Rama.
Yeah, thank you so much, Dr. Petole, because this has been a very burning question in India. Any forum we go and we want to use probiotic, or we want to even recommend that probiotics can be given in very low birth weight baby or preterm babies, there are always big question marks. And some people are really not in favor of that. So my request is that if all this compilation can be made available, especially to the pediatricians, to the clinicians, because if there is a evidence, one should not doubt. And it was very convincing, talk. And I'm sure I am 100% convinced, which I was to some extent already. And there may be many more people who can be benefited. So the only question or the challenge remains which probiotic to be given in Indian context. So whatever, data you have, if you can even, shortlist that these are the probiotic strains which have shown successful result in other countries, well, we can certainly use those. And nowadays, it is not so much of problem of importing the strains, because many of the strains are being, the bacterial strains are taken from abroad, and many companies are producing those in mass scale, high scale production here itself. So once that particular question mark is settled, the production can be done in India. There's a lot of, companies who are available, and these probiotic strains can be made available to clinicians to be used. And I think that will really be very, very beneficial. Sure. Thank you so much for a wonderful talk. Thank you.
Thank you. I think all I can say that Over the last 3 years, I have gone through every tertiary neonatal intensive care unit in India, and the reality is no one has got any idea about the actual evidence, and everyone is terrified of the red tape and the bureaucracy when it comes to paperwork, to importing things. So sitting in the higher office, the paperwork might look quite easy, but for a working, busy clinician, if you want to ask him to finish the paperwork, they would not do it. So that's the problem. So hopefully our next paper will be specific updated guidelines where we will say which strain / or a product has got what level of evidence. That's the one you can import. Thank you.
Yes, sir.
Sir, I could see a lot of your data which was pointing towards the preterm babies. Yes. Do you have data on the term babies? Like, can these strains be used in term babies?
Basically, very limited evidence. People have worked quite a lot on allergy, atopy and eczema type of issues. Not many randomized control trials, very poor quality data and no significant benefit. Just for one of the inflammatory disorders of the gut, there is reasonable evidence, ulcerative colitis and other things, that yes, some of them can induce remission and prevent relapse. But no impressive data like what you have of preterm babies. And the reason could be most of the research in term big babies is focused around only few strains and products. So one of my colleagues, the title of his paper is The Ethics and Politics of Probiotics. So that gives all the answers.
Sir, one last point or suggestion is, like, if you could compile all this and put it in the form of a chapter, contribute a chapter to a textbook. For example, as a clinician, we look forward to get evidence from textbook. Say if this whole thing is put in IAP textbook or some of the textbooks, that will be great.
That book was supposed to be released just on 6th of December. It may be published. Have a look.
Oh, thank you so much.
So I have one question for you and then 2 comments.
Sure.
My question is, in India, 70% of newborn babies die within first 7 days of life.
Yes.
40% are dying during 24 hours.
Yes.
Do you think there is a role of giving probiotics to a woman who is pregnant? And then it can reduce sepsis and infection in that?
Yes,
baby?
perinatal probiotics, there are already 2 systematic reviews that giving probiotics to the pregnant mother and then either for the first 6 months to the baby or first year to the baby is safe and it is potentially beneficial. And giving probiotic to the pregnant mother has been shown to temporarily result in colonization of her baby, at least for the first couple of weeks. So if first week of life is such a bad period for the newborn baby in our country, why not? So again, it's a good subject for a randomized control trial for our kind of setup in India.
So my 2 comments are, the first one is, the story of antenatal corticosteroids.
Yes.
And how people kept on generating evidence for 15 years.
Yes.
Before, in 1994, it became a standard of care.
Okay.
The story with probiotics is exactly the same.
Yes.
It will take time while it becomes standard of care.
Correct.
And then the second thing is, we need to show, as an implementation research, in situations like India, in large, big studies, that some product is really safe and it is giving all the benefits which you showed in your study of NEC, decreasing mortality and decreasing time to fulfill. This is my second comment.
Yeah, that's fine. Basically, for example, when we started to use probiotics routinely, we did not go for a large definitive randomized control trial of the specific Bifidobacterium brevi that we use in Western Australia. We knew that there was enough evidence out there to trust, including experience of routine use. So all we did, we conducted a pilot randomized control trial to assess safety, tolerance, ability for it to increase the bifidobacteria count in the babies. And once we're happy with that, we introduce it as a routine use. And then we published data of 3 years before compared to after, and then we showed that our sepsis, death rate and NEC went down. So that's the shortcut to use.
So I know you know the story of use of antenatal corticosteroids.
Yes.
Evidence coming from West, while it is used in India, it
Yes.
gives you different results.
Yes.
It increased the mortality, increased the purpural sepsis.
Absolutely
So
correct.
I think we need to show that as a implementation, big research here, that is safe, it is doing benefit,
Correct.
and the results are the same.
Absolutely correct. Because for any research, setting is quite important.
Yeah.
Correct? Yeah.
Thank
But
you.
luckily,
Thank you.
the
Excellent
benefits
talk.
of probiotics are quite dramatic, which are the priorities for the developing countries. Death, nutrition, and dying from NEC.
Yeah, so you know, in the developing countries, breast milk is thought to be like a vaccine. No one will like to give anything in addition to breastfeeding to the baby during first 5-6 months. So that becomes a barrier, changing people start giving something which is external. Thank you, excellent talk, and I think you convinced us it is doing great for babies who are VLBW and ELBW. Thank you so much.
Yes, sir. Thank you so much. We really appreciate Dr. Sanjay Patole's talk. And we'll just like to request Dr. Darari to please honor Dr. Patole with a memento. I request Dr. Shrivastava to come and please honor Dr. Darari. Yeah. I'm wishing you good health. That's more. He's an ICM right now.
Good evening all. Now we are moving towards the session 4 of the symposium, that is probiotics and antimicrobial resistance. Now I would like to invite Dr. Rajesh Kapoor as the chairperson of the session. He is working as a senior consultant at India TB Research Consortium, ICMR. He has been as a senior advisor and scientist H at the Department of Biotechnology. He played a role in elimination of polio from country as managing director of Bharat Immunologicals and Biological Cooperation Limited. He was also the trustee of the Wellcome Trust DBT TB India Alliance. He served in various positions in the Department of Biotechnology since 1993 and was actively involved in biomedical research. He specializes in core and cross-sectional policy issues of biotechnology development, regulation, safety, public-private partnership, international relations, and biotech R&D innovation and development, and public concerns and consensus building. Now I would like to invite Dr. Malini Sharif. She is the head of Department of Microbiology, Vallabhbhai Patel Chest Institute, University of Delhi. Her area of research is antibiotic resistance.
Having said that, it is my honor to invite Dr. Nair, whom I know since past more than a decade, to present his work on probiotics as a solution to antibiotic resistance. Now, this is the big question. Can probiotics prevent antibiotic resistance? Now, here we are to answer this question.
Good afternoon, and chairpersons and distinguished members of the audience. Today I'd just like to start with thanking Dr. Rama Chaudhary for this invitation, and also thanking the Probiotic Association of India to call me here to give this talk. Thank you very much. I just want to make a change, not a change, I'm not too sure how the article title came in the program as probiotics as solutions to antimicrobial resistance. It's actually, this is my title, Can Probiotics Reduce the Use of Antibiotics? I would like to be humble up here. Antibiotic resistance is a large problem, and I don't think solutions will come from just one thing. But I'm sure probiotics is going to play a role in some small way, and that's what I'm trying to elucidate in this talk today. Before I go into the details of the talk, I would just like to go across the history of this. There are certain things which history itself tell us, and I'd like to go through that. and I call it as the rise and fall of antibiotics and probiotics. Not many of you would know that in 1882, Metchnikov discovered phagocytes, and that's a very interesting story. Is he put thorns into starfish larvae and then saw the cellular exudates coming to the tip of the thorn, and what he thought was protective, and he used the term phagocytes to describe these. And that gave rise to this field of cellular immunology, and for which he got the Nobel Prize in 1908. Now, as a function, he thought phagocytes kind of chewed up toxins which were released from the colonic flora, and he was of the opinion that the colonic flora should be completely cleaned up and replaced by other beneficial bacteria. And he had gone to the extent of also suggesting widespread colectomies. But instead, he chose the replacement of native flora with friendly exogenously introduced flora, which we call as Bacillus bulgarius. And this was in the 1930s, and it's about the same time when Dr. Minoru Shirota discovered Lactobacillus casei shirota. In 1940s, the heydays of lactobacillus therapy came to an abrupt end with the advent of sulfur drugs and the discovery of antibiotics. And then started this whole thing of war on bugs. The discovery of growth-promoting factors of antibiotics also gave a plus to antibiotics. And the talk about friendly bacteria receded into the background. Medical scientists became aware of the potentially negative impact of antibiotic administration on human beings in the 1950s. And so that brought back probiotics again into the limelight. But this is just to give you a timeline of the history of antibiotics. It's a very crowded slide, but what we have done is we have got all the antibiotics that have been discovered and deployed in clinical practice. And in the column below the line is the emergence of antimicrobial resistance to that particular antibiotic. And as you would see, mostly antibiotic, most of the resistances that came in about 3 or 4 years after the discovery of the concerned antibiotic. And till about 1970s, these antibiotics were discovered. And after 1970s to date, there have been very few discovered. I think it's only about 3. And so this is the history, this is the time encapsulation when these antibiotics came into play. And then what I call as the resurrection of probiotics, this is in the 1950s to 1970s, with the advent of probiotic term emerged in a variety of contexts and in between these years. The mid-90s and 2000 witnessed exponential growth in probiotic research. And in 2001, the definition came, the term microbiome came, given none other by Joshua Lederberg, and this entered into literature and gave a great boost to study on probiotics. The microbiome referring to the collective genome of our microbial inhabitants. And as of present day, I mean, anything you open, it's related to the microbiome, and probiotics is coming up in a big way. This was subject to intense medical research, multi-billion-dollar industry globally. The probiotics joined by concepts such as prebiotics, metagenomics, holobionts, fecal microbial transplants came into being, bacterial translocation from intestinal lumen to bloodstream. So what I was trying to get across to you is that there has been these ups and downs in the life cycle of antibiotics and probiotics. And at least I believe firmly that this probably is a time when probiotics will also again come into the limelight, especially in the light of antibiotic resistance or antimicrobial resistance, which is really consuming research efforts across the world. So therefore, as we move from Metchnikov to microbiome, we find ourselves in a time of optimism indeed for the potential intellectual and therapeutic haul to be derived from such research. Actually, if you see, probiotics and antibiotics are two opposites. Probiotics is a live microorganism. This you must have heard it a million times in this meeting and elsewhere, which when administered in adequate amounts confer a joint benefit on the host. Antibiotics, in contrast, are substances that either prevent the growth or kill a living organism and are considered miracle drugs. The term probiotic is related to preventive medicine rather than therapeutic procedures and is thus considered the opposite of antibiotics, whereas antibiotics can enhance human lives by treating or preventing diseases. But what has been the problem with antibiotics is the appearance of antibiotic resistance, which has now almost been reported for every antibiotic discovered and has become a most urgent public health concern that weakens in a global way the usefulness of antibiotic treatment of infectious diseases. It's one of the priority programs of the World Health Organization at this point. Just to give you a scale, I'll be relating about antibiotic resistance. And so what are the consequences of antibiotic resistance? Simply is the inability to treat common infectious diseases. I work on enteric diseases. At one point, we are very close to a point where shigellosis became almost an untreatable disease because none of the antibiotics worked. Likewise, in organ transplantation, cancer, chemotherapy, and major surgeries, where you always have an antibiotic cover, these are going to become very risky procedures in the future as the way antibiotic resistance is growing. And then, of course, it increases the cost of healthcare. You go on trying with different antibiotics. The Millennium Development Goals are at a risk. We had definite goals for the Millennium MDGs, and these are receding into the background. And of course, there's a danger of not achieving the Sustainable Development Goals, which is for the next 15 years till 2030. Okay, just to give you a snapshot of the global epidemiology of antibiotic-resistant bacteria. Say, for example, in North America, there are about 99,000 deaths per year from infections acquired in hospitals. And it costs the United States about 21 to 34 billion per year. Likewise, in South America, Northeast and Middle East and North Africa, Sub-Saharan Africa. In Europe, the cost to society is about 1.3 billion per year and 600 million days of lost productivity. Asia is not far behind. Asia is also in the rump of ARBs, or antibiotic-resistant bacteria, flowing in. Take, for example, India. Within the last 4 years, from 2002 to 2006, antibiotic-resistant bacteria went from being resistant to 7 to 21 drugs in the period of 4 years. In Pakistan, 71% of the infections in newborns are from antibiotic-resistant bacteria. So this is at a global scale and at a national and at local scale, just an unimaginable problem which is which is confronting us right at this point. Some of the examples of alarming resistance: when I started research, fluoroquinolones were not there, but then they came in, a very popular drug for enteric infections. Now 30% of the enteric bacteria are resistant to this drug. Likewise, for E. coli bacteremia, ampicillin resistance is as high as 55%. Staph aureus, we have the era of vancomycin resistant Staph aureus coming in. And likewise, Salmonella enterica, a special type of type which is known as D104, is resistant to ampicillin, chloramphenicol, streptomycin, sulfonamides, tetracycline, and ceftriaxone. So it's something which you have to sit back and carefully think about. Let's come back to India and see what the resistance pattern is. If you look at the column on the right of my right, the resistance rates are unimaginable. 96% in furazolidone, cotrimoxol, and nalidixic acid. These are Vibrio cholerae resistant strains picked up from stool samples. Likewise, you see 98.2 for Klebsiella species, 93.5 multi-drug resistance, Klebsiella pneumoniae. So it's just unimaginable what would happen in the next few years when they become resistant to as many as 22 drugs. We have Vibrio cholerae which are resistant to about 22 drugs. Fortunately, they are not prevalent still in the clinical scene. This again comes out from the Baker's oven. It's data from the THSTI, and this is very recent data, just showing you the number of antibodies which resistance is detected. If you see on the table on the left-hand side, my left, you'd see the resistant rates are just climbing. For some reason, between 2010 to 2011, there was a spike, then there's a plateau, and 2015, it's close to about 9 antibiotics per strain. Likewise, for against the different species that have been isolated, look at Klebsiella pneumoniae, almost 13 number of antibiotics to which resistance is detected. So it's not a pretty scene. And what is being predicted for the future is death from antimicrobial resistant infections and other causes in 2050. 10 million deaths of antimicrobial resistant infections are anticipated in 2050. And that's going to be more than anything else, including cancers, diabetes, diarrheal diseases, and the lot shown in this slide. So there is a need to get worried about this. Apart from that, antibiotics on the gut microbiota, I would like to let you know is that I'm not a critic of antibiotics by no means, but are they going to be effective the way we are going to we abuse them is the question that I'm trying to get across. Say, for example, antibiotics, what happens to the gut microbiota when you use antibiotics irrationally is you deplete the bacterial diversity, the taxonomic richness and evenness, all of which we know. I don't have to explain about the microbiome, the gut microbiome particularly. So you become increasingly susceptible to infections. Then the establishment of resistant bacteria, accumulation of antibiotic resistance, and the untreatability of bacterial infections results from that. You have deregulated metabolism, as a result of which you have obesity, metabolic syndrome, and diabetes. And of course, the disruption of the immune system, the Treg-Th balance, and disrupting the immune homeostasis. These are some of the collateral damage of abusing antibiotics. This slide just shows you the impact of antibiotic administration in a bacterial community of the colon. If you see that before antibiotic treatment, there's a richness in the flora, as shown up here. The green bacteria, the green bars are the beneficial bacteria, and then as soon as you treat with an antibiotic, you see an explosion of antibiotic-resistant bacteria, which tends to prevail even after the antibiotic is withdrawn, and it takes time to restore your normal flora. One still wonders if you get back the same flora, but these are some of the impacts of antibiotic resistance. So while new antibiotics are urgently needed, there's no question, we have not been very successful in this area. Alternates to antibiotics that can preserve the value of existing antibiotics, please, that's an important, that preserve the value of existing antibiotics and reduce the need for antibiotics can be valuable addition in the containment of antibiotic resistance. And giving you that background, I ask you to think about this question is, what is the potential of probiotics to prevent the need for use of antibiotics? Given the background of probiotics, this is just to again reaffirm the definition, live microorganisms. Probiotics in different clinical conditions as an infant, as a child, as an adult, The the ones written in bold are the conditions which respond to probiotics, like for NEC, which the previous speaker spoke about, acute infectious diarrhea and acute antibiotic-mediated diarrheas for childhood, and for adults, including elderly, acute antibiotic diarrheas, mediated diarrheas, lactose maldigestion, and pouchitis. These are ones where probiotics may play a role, or there is evidence at least. I'll quickly go through this because you might have been, you might be getting tired of these meta-analyses, but given they are source of interesting information. Like, for example, NECs, probiotics using strains, a variety of strains, prevent NECs showing reduction in the frequency and overall mortality. Likewise, for gastrointestinal diseases, probiotics are generally beneficial in prevention of GI diseases. Treatment of acute infectious diarrheas, there's a shortened duration of diarrhea and reduced stool frequency according to a Cochrane review of 63 studies. Likewise, for prevention and treatment of antibiotic-associated diarrheas, meta-analysis of 82 RCTs have shown that probiotics is associated with reduction in AAD, and prevention of Clostridium difficile-associated diarrhea. Again, review of 31 RCTs has shown that it reduces the risk of developing CDAD by 64% in children and adults. I'm just trying to give you a snapshot of the importance of probiotics, or as deduced from reviews, meta-analysis, systematic reviews, etc. Same for treatment of irritable bowel syndrome, common infectious diseases, non-alcoholic fatty liver diseases. I'm not going to read the other parts, but probiotics do seem to work under certain situations, and that's what we should capitalize when we look at probiotics as something to encounter antibiotic resistance. I'll quickly again go through one of the largest community-based trials, randomized double-blind placebo-controlled field trial in an urban slum in Calcutta. This was a group led by Dr. Deepika Shur who did it. The probiotic was Lactobacillus casei strain Shirota. This is a quick schematic diagram. There were 3,758 children included in the study between 1 to 5 years. It was a double-blind controlled trial. It was done to determine and compare incidence, duration, outcome, and pathogens of acute diarrhea. The probiotic, one arm was a probiotic drink, and the other was a nutrient group without the probiotic. And this was given for 12 continuous weeks on observation of 65 ml per day, and followed up for another 12 weeks. I will not go into many of the details of this trial, but just to tell you, there was 0.88 cases per child per year versus 1.029 cases per child per year incidence of diarrhea, which meant that there was a protective efficacy of 14% in the probiotic group. And these are from slums of Calcutta where diarrheal diseases is endemic. So that was pretty impressive, we thought. The reason I'm giving you this data is this particular slide. This particular slide is the WHO's Global Action Plan on Antimicrobial Resistance. And if you look at strategic objective 3, is reduce the incidence of infection, and probiotics would certainly contribute to that. So by reducing the incidence of infection, you reduce the prescription of antibiotics, and by reducing that, you obviate the occurrence of antibiotic resistant bacteria. So that's where probiotic is going to play its role, if at all, and it will be an impressive role if it does happen. How can probiotics help? Probiotics can stabilize the gut microbiota and reduce the incidence or the risk of GI and extra-intestinal disorders such as IBS, IBD, and vaginal infections. Enhance innate and adaptive immune responses, which in turn aids in the eradication of pathogenic organisms, decreases infection. So the emphasis is reduction of infection, and that I could say would be the role that probiotics would play in reduction of AMR. And it also, probiotics has, could also reduce the risk of antibiotic-associated diarrhea and Clostridium difficile diarrhea. Safety of probiotics. Probiotics do not contribute to the spread of antibiotic resistance and may even reduce it. Members of Lactobacilli and Lactococcus, commonly designated as GRAS, are generally regarded as safe or qualified presumption of safety. And importantly, intrinsic resistance, minimum potential for horizontal spread. And this is under a great deal of investigation, why intrinsic resistance does not spread, especially at the CDC in the United States. So let's kind of wrap up that, and these are the last two slides which I'll just sum up. The evidence that probiotics can augment antibiotic action is it can reduce the risk of antibiotic-induced superinfections in the gut and vagina, and that would play a role. Secrete antibacterial substances that lower pathogenic bacterial populations locally and at distant mucosal sites and disrupt biofilms. And also enhance generalized mucosal immunity, which in turn aids in the eradication of the organism at the mucosal site. With that, I would like to conclude stating that probiotics could be used as prophylactic measures to reduce the risk of infection and thereby limit antibiotic consumption and increase human health development. When choosing to use antibiotics in the treatment of prevention of gastrointestinal disease, the type of disease and probiotic strain are the important factors to be taken into consideration. And in the first phase, probiotics should be used as adjuncts to antibiotics because their activities might not provide sufficient therapeutic benefit as a single therapy. And combination of antibiotics and probiotics can provide the additional advantage of reducing the evolutionary pressure for development of resistance. Thank you for your attention, and in terms of acknowledgement, I would like to acknowledge Dr. Nija Hajela and my colleague Dr. Bhavtosh Das, who helped me to put this talk together. Thank you very much.
Thank you, Dr. Nair, for eliciting the resistance in worldwide and in India, and it's a very big problem. As a clinical microbiologist, I can understand how depressing it is to know that most of our bugs are 80% resistant to most of the drugs. So if we try to find out if these probiotics given together with antibiotics can at least reduce the resistance, or even it can reduce the dosage and other things, then it would have a very good effect on us. So since we are short of time, maybe we can take a question or two. Yeah.
Suppose we give probiotics which are susceptible to number of antibiotics. You're saying no, you have to give simultaneously both probiotics and antibiotics.
Yeah.
How do they match now? How they?
Yeah, that's what a study which Dr. Sanders showed yesterday, I think, in Botswana, where you took an antibiotic and probiotic together. And
one more thing, sir. We can do the antibiotic sensitivity before giving the probiotics.
yeah, I mean, that
Can we
depends.
do antibiotic sensitivity
Yeah.
for those probiotics which are giving, we are prescribing? Can we do that one, essay?
Yeah, I don't see why you can't do antibiotic sensitivity.
But we don't do no. We are whatever there in the market we are putting.
Putting,
What
you
we are
mean a
giving?
I did get your question correctly.
See, sir.
Yeah.
Yeah.
The antibiotic susceptibility
See, we are going to give antibiotics and probiotics simultaneously.
yeah.
Some of the probiotics may go off because of they are susceptible to some of the antibiotics.
Yeah, okay.
Thereby there is a remand for testing the probiotics in the lab or anywhere.
Yeah, yeah.
With the
of
report,
course.
then give the
Yeah.
probiotics along with the antibiotics.
Yeah, yeah. I get
That will answer.
Yeah.
Okay, sir. Thank you.
Yeah.
Just want to respond to that because it's what we study. So I understand what you're saying is that the probiotic will get killed by the antibiotic. But right now, if you look at the research, that's a theoretical thing. So some people will say wait 4 hours to take your probiotic, but that's not based on clinical data. That's just what people say. So, I mean, you can say that if you want. I don't tell my patients that because I think compliance will go down if they're taking them separately. But I think you could. It'd be reasonable to say that.
So what I mean to say is if the probiotics available in the market are sensitive or resistant to certain antibiotics, that should be labeled.
The question is, should if the probiotic is resistant to an antibiotic, it should be labeled. Yeah, I mean, labeling's a whole separate talk. I'm not going to argue with you.
It's a very relevant question actually because many of the probiotic strains, when they are given with antibiotics, they may not be able to survive. Exactly. That's what you are saying because the antibiotics may kill the probiotic. So it will depend that for which purpose you are giving probiotics. If it is given for along with antibiotics, it may be wise to check the strains and check whether the probiotic strain is susceptible to that particular antibiotic and give those strains which are resistant to that. So, though it's not a good marker to give the resistant strain as such, because there is always chance of resistance transfer, though data doesn't show that. But still, in our study, when we had to give for antibiotic-associated diarrhea, we checked all the strains and we selected only those strains which was resistant to the commonly used antibiotics. Because then only they will be able to persist in the gut, otherwise they will be killed. So it will depend on for what application we are using, which particular probiotic, and then we can use
No,
it.
so Dr. Chowdhury, would it mean that you do the susceptibility of the probiotic strain and the etiologic strain also? Both
Yeah.
together, right?
We did, it is not that we checked for the strain which is causing the disease, they are separate. What I am trying to say is that when we are giving for, say for example, for antibiotic associated diarrhea, we know that these are the commonly used antibiotics which are being given to the, in the clinics. So we have to give a probiotic which can at least survive or which can resist those antibiotics. Otherwise there is no point of giving. So that is what was his question. So it will depend for what application we are giving. If I am giving for IBD, I may not be worried so much about antibiotic resistance there. So that is why Mary yesterday was saying that every strain is unique and the application of the strain in which particular disease we are using, you have to weigh that. So it cannot be one probiotic for all, it can't be one strain for all, or it can't be just a general formula. So that is where the basic research is required.
So ma'am, a recommendation has to be spelled out on that, like which strain has to be used for which disease condition.
That is what we are trying to do.
Just a quick comment in response to this issue of labeling an antibiotic resistance pattern for a probiotic. I mean, that question deals with the safety of a probiotic. In other words, if it's got an antibiotic resistance phenotype, is it somehow going to be unsafe? And I think it's really important to recognize that many probiotics are resistant to certain antibiotics, but that resistance is an intrinsic resistance, not a transferable one. And so one of the important safety parameters to get a GRAS affirmation or to be qualified presumption of safety, I know in the European system, is documentation of the absence of transferable mobile antibiotic resistance genes. So properly screened, safe probiotics are not going to be a risk for transferring antibiotic resistance.
Thank you.
No, intrinsic. So no more questions. I just have a comment like from what Dr. Mary has said So I think one of the criteria for choosing the probiotic strains should be that it should be like intrinsically resistant. That's what I get. And that should be one of the factors to be considered when we choose a strain, isn't it? Yeah. 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 Yeah, because the horizontal transfer will occur. So, yeah, yeah, that's one. Okay. No more questions, and thank you, Dr. Nair.
Oh, most welcome.
Now we'll call upon our next speaker for the day, Professor Dan Mersenstein. I think most of you have heard him in the morning also. He'll be speaking on does probiotic consumption reduce antibiotic utilization for common acute infections, a systematic review. So Dr. Mersenstein, please.
So I didn't realize I was falling, which I have a similar slide. I'll just skip over it. But we were really interested in this from 2 points. One, is it going to decrease antibiotic resistance? Besides studying probiotics, I study antibiotic resistance, and I was really interested, can I combine them? And then 2, it gets to the question is, should healthy people be taking a probiotic? And that's what we're sort of getting at with this. No changes here. So I'm going to discuss the rationale for probiotics, decreasing antibiotic usage, consider if everyone should take a probiotic, and recommend some steps forward. So most of my data is US, I'll point out when it's not, but nearly 13% of all medical visits result in an antibiotic. The number one reason is sinusitis. If someone comes in and says they have sinusitis symptoms in the US, 90 to 95% of the time they get an antibiotic. We know bacterially it's probably 5 to 10% of the time. So they're almost for sure getting an antibiotic for viral sinusitis. Even assuming they really have bacterial sinusitis, the number needed to treat, and this is in clinical trials where they waited 10 days, they had all the clinical indications. This is not what we see in practice. In practice, it's 4 or 5 days, even less. But if they wait, the number needed to treat is 18. And remember, we talked about this morning, the number needed to harm is 8, much lower. Some data, a study I did with the CDC, we were very conservative. We looked at all the data and said, is it a possibility someone should get an antibiotic for this indication? First, we found that 1,000 people visits, 506 result in an antibiotic. So half the visits result in an antibiotic. Again, being really, really conservative or liberal about how you define that, 353 antibiotic prescriptions were probably appropriate. I argued much less, because that's assuming that most of the sinusitis ones are appropriate. The ones we assumed were appropriate were things like pneumonia, UTI, strep with a proven strep, quick strep or culture, but also sinusitis, which really, again, I told you the data, it's mostly a viral sinusitis. The Public Health Foundation of India also talks about the reasons of antibiotic overuse and the lack of access. And I listed their 5 recommendations because they were very similar to the ones we have in the US. I thought it was interesting. The first one is not. Lack of microbial facilities, that's not a problem we have in the US, but I guess it's a problem that they recommend here. The ones we do have is doctors overprescribing to any patients with a fever, taking that as a sign of bacterial infection. So fever is a sign of bacterial infection. The other one I see is if you have discolored nasal discharge, they consider that a bacterial infection, which again, just means you have an infection, does not mean it's a bacterial infection. Patient expectation, that's a big deal in the United States also. In the United States, doctors get graded satisfaction. Sometimes it even impacts their income, and so it's a big deal of patient satisfaction. Desire pharmacists and some doctors to make a profit from drug sales, that's more an Indian issue than a US issue. Most doctors don't make it, and pharmacists in the US are not allowed to give probiotics out without a prescription, so it's not such an issue. And the public's lack of knowledge about the inappropriate use of antibiotics, and that is definitely a problem that we see in the US. Interestingly, it's the second most common reason to go to the ER for an adverse event is antibiotic usage. The only thing that's more common is anticoagulants. And we think of anticoagulants as so dangerous, and maybe the people in this room think of antibiotics as dangerous, but most people out there don't. In kids under 19, it's the #1 reason to go to the ER for adverse event, with 6 of the 7 top drugs that cause adverse event, and amoxicillin alone causing 21%. A lot of people think amox is such a safe drug, or penicillin is such a safe drug, but it causes lots of adverse events, including all the way to anaphylaxis. So I already presented this data this morning. If that's me making noise. But it's a Cochrane review of acute respiratory infections, and they found a 47% reduction in persons experiencing upper respiratory infection, decreased the sickness by 1.9 days, and did find reduced antibiotic use in cold-related school absences. This is a study Mary Ellen did with other colleagues, Sarah King, and they reviewed 20 studies for a meta-analysis and found the average decrease in illness duration was 12 to 24 hours. And again, if you remember from this morning, it's very similar to what you're going to see with the flu drugs and with treatment for otitis media and even strep. Again, I think this is already just presented, but per the CDC, there's about 2 million cases of antibiotic resistance in the U.S. with 23,000 deaths. Of course, the #1 issue is we can and should prescribe less. There are places in the U.S. that are doing this, places like Kaiser that have done really a nice job with decreasing antibiotic usage. From my understanding of the Indian system, it's a little less centralized for sometimes, and people do prescribe or just go get antibiotics much more. I'm happy to talk about that. But the other option is to decrease illnesses, sort of what Dr. Nair was talking about, or visits or even indications to give antibiotics. So not giving him at the same time simultaneously, but actually getting the patient not to come to the doctor, getting the patient not to go looking for antibiotics if they get better on themselves. And that's where probiotics may fill a role. Again, we've already heard from many other people that they've shown to prevent common illnesses, potentially multiple mechanisms for that. Probiotic consumption has shown to reduce the symptoms also, not just the actual illness, but the symptoms of it. And it may help, like as I said, patients hold off on antibiotic usage. So we conducted a meta-analysis. We searched 13 electronic databases, screened over 1,500 citations, and found 17 RCTs that answer this question. And we used a grade system. So the 17 RCTs examined the role of probiotics in preventing acute respiratory infections, acute lower digestive tracts, or acute otitis media. So they weren't looking to decrease antibiotics. They were looking, does it affect upper or lower infections or otitis media. In infants and children, we saw a 29% decrease in being prescribed an antibiotic if you were in the probiotic group. When we restricted this to the 5 studies that were the lowest risk of bias, we saw a 54% decrease in taking an antibiotic if you were on a probiotic. This is our forest plot, and you can see 29% decrease. You can see if you want to look up all these studies. I can send you the slide. This is, I should say, this is under review. This is not published yet, but it's at a journal. Again, we already talked about it, but I just want to remind you again that the influenza vaccine, the number needed to treat influenza-like illness is 40, and for actual influenza is 71. And then for the treatment drugs, the ones that patients are begging for, it's 16.8 hours improvement. So what should we recommend? That gets to the question, and I don't think it's a reasonable question when it comes to NEC, because I think NEC is much more clear. But if you look at the original meta-analysis Dr. Sanders did, or the newer one, there are different strains in different species used, and it's really not clear. I do think it's really important for those in the audience and other people who are doing probiotic research to collect this type of data. This type of data of how we keep healthier people healthy, or how we prevent people from getting iatrogenic or doctor-related comorbidities. And then the final question, which I started to address this morning, should everyone take a probiotic? And I don't think we're there yet. I think the data is getting more robust when it comes to decreasing antibiotic usage, decreasing respiratory abuse, respiratory infections, maybe with the blood pressure and the LDL, there's some data. But if you're going to raise your hand and ask me which probiotic you should take, I'm going to say I don't know. So that's why I don't think we're there yet. But I think we're much closer. And if you asked me this 5 years ago, I would have told you were crazy. There's no chance of that. But we're much, much further than we've been. I just want to thank my colleagues and thank ISAP. This was brought together by ISAP, bringing us 2016 to a meeting. We had a discussion group, and it came out with this paper. So thank you very much for your time.
Thank you, Dr. Merenstein. Again, the floor is open for any questions. Actually, I have a comment, Dr. Merenstein. It's just a thought that, once we are going to add antibiotics and probiotics as a thing, then I think the dosages and all these things will vary. So there's a lot of work which has to go to, reduce the dosage of the drug to be given, when you're giving probiotics along with it and things like that.
You think the dosage of the probiotic will vary?
No, dosage of the drugs itself.
Bo-
If
bo-
it's
bo-
going to have a positive effect, additive effect, and we are talking about bringing down the dosages of the antibiotics by giving a probiotic.
Yeah, I think you're probably right. I think more importantly in my mind is we were always told, the teaching always was, you need to finish your antibiotic prescription. And the new teaching is that's probably not true. When you're better, you should stop. So if the probiotics can get them better a half a day, a day and a half, and they can stop the antibiotic earlier, to me that's going to be really important.
Okay.
Since I have the floor, I'll say one other thing. When it comes to the neck data and this kind of data, and the argument that we don't put strains together in probiotic is not fair, is again, I think you need to think back of what we do in medicine. When we have meta-analysis that say antibiotics are good for pneumonia, or antibiotics used for urinary tract infections, we put different antibiotics together. We do that on a regular basis. Again, you need to know which antibiotics to take. You wouldn't take amoxicillin for meningitis, but you say meningitis is treated with antibiotics due to the meta-analysis we put together. It's the same with probiotics, with neck, respiratory infections, GI infections. So that's my soapbox. Thank you for your time.
Thank you. So now we move on to the next speaker of the day, Dr. Anselm D'Souza, and he'll be speaking on relevance of anaerobic bacteria as probiotics. He is the Managing Director of Sayagia Life Sciences Private Limited, a fermentation-based company situated in Maharashtra. Dr. D'Souza, please.
Thank you, and good evening, everybody. The topic I'm going to speak on today to you is the relevance of anaerobic bacteria as probiotics. And not only the need for such a probiotic, but also the challenges in manufacturing such anaerobic bacteria, because the fermentation is totally different from conventional probiotics. Now, many of you might equate anaerobic probiotics with lactobacillus and bifidobacteria. But this is partially true, but the bacteria we are going to talk about today, and which is on the route to commercialization, is an anaerobic bacteria that if you expose it to air for a few minutes, it loses its viability. These are called the next generation probiotics and are found to a large extent in the gut. And like so many speakers have spoken today about butyrate, they are implicitly connected with production of butyrate in the gut. These are called the next generation anaerobic probiotic. And besides talking on the production, we'll also see how they contribute to gut health. And to the best of our knowledge, as of today, there is nobody in the world who has commercialized these two anaerobic probiotics. And if anybody has any knowledge, we would be happy to hear about that. I got this slide from an article in Nature, and you can see from the slide it's very clear how the interest in the gut microbiome has exponentially risen in the past few years. Now, this is mainly because of high throughput screening and then sequence methodologies which have lowered the cost of analyzing a sample, and also sample processing time has come down. And the other thing is that it has also been realized that what happens in the gut goes to various parts of the body, like dysbiosis in the gut is linked to autism, depression, diabetes, obesity, and not just IBD and UC as was originally thought. I think this is a slide that most people will be familiar with. You all know that the commonly used probiotics are Lactobacillus, Bifidobacterium, Bacillus, some yeast. And the colonizing sequence is very common. First you have the enterococci. Once the oxygen level goes down, you have the other groups. And finally you have the microaerotolerant Lactobacillus and Bifidobacterium coming up. There is one point I would like to make here on Bifidobacterium. If we say that these two anaerobes, which we are going to talk about later, are helpful in relieving symptoms of IBD and UC, how does Bifidobacterium work? Bifidobacterium has been implicated in producing lactic acid, and this works in a so-called cross-feeding. The lactic acid which is produced by Bifidobacterium is used by the two anaerobes to produce the other short-chain fatty acids like acetate propionate and ultimately butyrate. So Bifidobacterium as a probiotic does have a lot of use. Then again, if 99% of the bacteria and the GIT are anaerobes, it only makes sense that if you want to correct dysbiosis in the gut, you don't go about it by giving a bacillus strain. And also if the bacillus strain or the lactobacillus strain can right the dysbiosis to some extent, imagine giving a true anaerobe would do a much better job. And most of the papers which are published tend to show that most of these true anaerobes produce a large amount of butyrate. For those people who do research in the microbiome area will find this organism, Faecalibacterium progeny, coming up time and again. Okay? In fact, it is touted as the next generation probiotic. And the only reason I put this slide up, because this is not the topic of the bacteria we are going to discuss today. The only reason I put this up is that it is cited time and again because it has lower than usual levels in the gut dysbiosis due to Crohn's disease, obesity, asthma, depression, diabetes, IBD. In all these cases, levels of Faecalibacterium progeny are 1 log lower at least. Faecalibacterium progeny is known to produce a lot of short-chain fatty acids, especially butyrate. Why is butyrate so important in the gut? The main reason why butyrate is important in the gut because butyric acid is the preferred energy source of colonocytes. It affects the cellular proliferation, differentiation, and apoptosis. Butyrate is again well documented as an anti-inflammatory agent, possibly through inhibition of histone deacetylase activity. Butyric acid also increases mucin production and therefore decreases gut permeability. In summary, this butyrate, it increases and strengthens the mucosal barrier and has very good anti-inflammatory properties. So much so that in patients with severe ulcerative colitis, butyrate enemas are given and also sodium butyrate tablets are given. But both these have challenges because enemas patients don't comply with so well, and for anybody who's worked in butyrate will know that butyrate has an awful smell. It really stinks badly. So it's not very easy for a patient to take butyrate tablets. So if one can have a bacteria which is colonizing in the gut and it produces butyrate, then it would be quite helpful. So this is the organism we are talking about, a Butyrococcus strain, and this particular strain and the work which I'm going to present now has been done along with researchers from University of Ghent in Belgium and a Belgium company called ProDigest, who has done the efficacy evaluation of the probiotic. What we have done is to commercially scale up using our strengths in fermentation. So I think earlier there was one of the speakers had said that getting probiotics manufactured in India are difficult. Is not the case, because a European company has come to us and seen our strengths and our GMP conditions and have given us the opportunity not only to manufacture this probiotic for the Asian region, but also to export to USA and Europe. So this culture, Butyrococcus, belongs to the Clostridium culture 4A, which are 4A and 14. Clostridium culture 14 are well known to have OTUs of butyrate producing organism. And if you look at this word pharmabiotic, it's very significant, because the way we are going about this is like a pharma drug. The whole genome of the organism has been sequenced. Antibiotic resistance is being proved to be below the EFSA breakpoints for MIC. Then it's also being shown not to have any toxic genes, no transferable resistant factors like plasmids. So all these are covered in the safety and toxicity of the strain. As we said earlier, it's a strong butyrate producer, and these are some of the in vitro tests. What is done in this case is Caco2 cells are grown and the trans-epithelial resistance is measured. Once it reaches a resistance of about 1000 ohms per square centimeters, it is challenged with an inflammatory stimulus. It's challenged with an inflammatory stimulus like TNBS, which makes the epithelium leaky. As a result of this, the resistance goes down. And when the culture filtrate is put into this model again, it has been shown that the TER again goes back to normal. So proving that there is something in the culture filtrate which preserves the gut integrity. It has also been shown to upregulate the tight junction proteins, like TJP1 is upregulated, and it has also been proven in an animal study